let me ask you about home safety. Do you get involved with any home safety issues?
Yes, we do. Especially when the nurse goes out, usually on the initial visit. The RN will do an evaluation of her surroundings, and just to touch base, they kind of do exactly what the geriatric manager would do, to check if it's safe for them to remain in their home. Is there rugs that need to be moved? They'll do a whole lot of evaluation, also the safety of where the medication is placed. They go through all those details as well. But so once a care plan is initiated, like she had shared, they also, the licensed physical therapist, depending on what their needs are, will go out and look at all those details. So just for example, which for your bedroom, the physical therapist will go out and do a detailed evaluation, whether at the bedside you may need a bedside commode, or in the shower you may need a shower. You know, every type of equipment that you may need, if you don't have, they will make those recommendations to the physician so you can remain in your home. So they look at the safety of all the equipment and to reassure that the resident is able to remain in the home and have the proper, whether it's a bar reacher, you know, for them to grab things, you know, if they're living in their home independently with maybe a caregiver a few hours a day. So our team makes sure that all their needs are met, and we communicate to the family as well that if we need to also coordinate ordering a ramp just to make the safety for our patient in their home more comfortable. So those are the other things that we go into detail with, but we like to make the environment a very comfortable environment. So we go through all those details, and we will certainly make the recommendation to our patient as well as to the family members so they can decide what is best for them. But mostly the medical equipment is certainly covered by the insurance, and then some other products that may be recommended, we work with the family in getting it very affordable. So they are safe in their home. Sure.
One of the things that I just recently ran across was a gentleman who was in a skilled nursing facility, and the social worker called me and said he can't return home because he has an unsteady gait, but also because his wife is a hoarder. And hoarding is a very big situation. Talk about safety. Not only can you attract pests and all sorts of unfriendly critters, but it can be a situation where it does create an area where they can trip and fall. So hoarding is a very, very big situation. We had another case where a woman was living in her home with a caregiver, and lo and behold, on the entire second floor, they had a huge infestation of not mice, but rats. So it's so important that people are being checked in on, and it was kind of funny, even though there was a caregiver in the home, there were still quite the evidence of vermin within the home. And it was just obviously a very unsanitary situation for everyone involved, but we see that as well.
I'm going to raise an issue over language, not an issue. Do you see that our language might change at all, particularly as the boomers now mature? I'm thinking of the term adult diapers. Adult diapers, I don't know. I mean, wow.
That's degrading for the senior.
It's degrading.
Yes, it is.
So I'm wondering if there's room for some new language, or the term caregiver, which automatically implies some kind of dependency. Case in point, 85-year-old cousin who needed some support in her house, and she kept saying, I don't need a caregiver, I only need her to drive, and I only need her for some general work in the house. And I said, what about a housekeeper who drives? Oh, she said, oh yeah, that kind of makes sense. So I'm saying, is there a language issue that you think we need to, and I guess it's a leading question, modify, because we have a new generation coming up that one's never going to get old, two is never going to be dependent. And are we going to change on how we talk about this to make it okay?
Let me just throw my 2 cents in on that. I definitely think the evolution is already happening. And you mentioned the word diapers. I mean, it's like a taboo word in our office. I mean, it's certainly not. It's either, incontinence products or that. I mean, I don't like that one, but use the brand name. Depends. Don't sound nearly as bad as an adult diaper. I will also say things like, we have many clients who refer to, and we refer to their care provider as a personal assistant. Because that's not entirely that's not inaccurate for many of our clients. It really is, helping to change the linens. It may not be hands-on personal care. It might be just helping with that sort of thing. Even we have many clients who have dementia or are unable to get out of bed or whatnot, and they will use a baby monitor to have in their room and in the caregiver's room, so that if they need to call for help at night, or they can do that. That also, I'm not a baby, why would I need a baby monitor? So there are, I think that evolution has kind of already started and will continue, and I think it's necessary.
Any other thoughts on that?
A big term that I get from a lot of referrals that we get from the nursing facility, and when our case manager would follow up upon discharge, usually within 72 hours, our nurse will go out and we would leave a message and to follow up so we can make an appointment so we could go into their home. Sometime the bar at the skilled nursing facility, the rehab centers, they say, well, a nurse will be out there to take care of you. And in that mind, they're like, well, why is a nurse going to be out there all day long, And what I find is when they would refuse care, and I would, they would say, Jenna, can you just follow up, because they refused, and we step back and we just immediately let the doctor know. And when I did speak to this particular client, and I said, our care is only for transition, for you to transition back into your home, and for you to receive the level of care that you need to remain in your home. And it's only could be a short-term basis. It could be within 30 days. It could be for 2 weeks. It's just really our job is to transition you into your home so that you can remain in your home safely, and to also monitor whatever skilled needs you may need. And for that, well, why didn't they say that it was for a transition? Because they felt that, someone was sending an RN and we were going to take advantage of it all, So, and I actually went back to this social worker that sent this referral, and I said, thank you so much, and I just wanted to tell you, the patient did refuse, but we did speak to her, and she feels good that she's going to transition with our team. And she goes, yeah, because she complained that we didn't want the nurse. In her mind, she did not really understand what we were going to do out there, but she had needed IVs, she had wound care. I mean, it was a complicated case. So, like I said, our job is really to transition you in your home environment, and once it's at an optimal level where we will release you back to your physician, then our job is done. So that is another verbiage I would say is the appropriate care, and especially if you're discharged from the hospital. You do need to transition back home, and our job is to make sure that you're safe. Okay?
I really agree. Approach is so important. Yes. The wording, the way you phrase things, your tone of your voice when you talk to someone is the most important thing. And we find that when we call our people to screen them to see about case management or care management. And one person can call with the wrong approach, the wrong attitude, forget it. But if someone says it the right way, in a simple way without too many technical medical terms,
right,
that it's understandable, then it's going to happen.
Great.
I was going to say, I think because the boomers are now getting into that, we are the generation that does not stay status quo. We are the generation that broke through the glass ceiling. We are the generation that changed the workplace. So as we are getting into needing the services, you're a perfect example. You didn't like what you found, so you changed it. Yes. And the boomers are the ones that are changing it because we don't like what we've seen in the going on. So we're going to say that's not good enough and make the changes.
Right.
Yeah, and you are the marketplace.
Yes.
You are the marketplace. Okay, questions, thoughts, Faith?
I
have 20 questions, but I'll do one at a time. For skilled services, what is the definition of homebound? I did do home therapy for many years.
Okay.
And if they went to the doctor, they were afraid to say, I stopped at the bank because I had to sign something over, and then they were afraid to say that.
Well, and I understand.
Did
this is-
everyone hear Faith's question?
Homebound, what is homebound?
Her question is asking, what is homebound? And this
skilled
is for skilled needs. In home health, this is a very huge thing. Doctors have to sign a certification and indicate why you need this skilled services. Now, you do not have to be homebound, meaning like bedbound. I know the term sometimes feels, we have a lot of patients that receive services, and which means we have, if you're limited, you need adaptive device. If you needed an adaptive device to, like for you to receive IV fusion, and you would need an adaptive device, meaning a walker or a cane, or if you need a wheelchair to go just to receive a therapy, it could be more, it could be a lot, it could be challenging for you to go to receiving treatment every day in a hospital. You would have to set up transportation, which could be very costly because there's not a lot of senior programs that have transportation. You know, and that's where FARA comes in, where she can help you with transportation. But we provide those services under, if you're limited and able to do things for yourself, if you need assistance to go to the physician, if you need assistance to, if something is a taxing effort. Okay, basically if it's, because a lot of people, well, I can't receive it because they said I have to be homebound. Well, I have this particular patient who was an amputee, and she felt, well, I'm not homebound, don't give me that, I'm not. But she was an amputee, and it was very taxing for her to go to the hospital to receive treatment. So those are justified needs. We have patients who have CHF, which is, who have previous strokes. And it goes again with, even they have previous, as long as it's a taxing effort. And you also, if you leave the home for 2 to 3 weeks, you obviously don't qualify for our services because you have to be.
Went to the bank.
Yes, that's justified, yes, yes. We have, and a lot of our patients do ask us, well, you know, I'm concerned if I go to the bank or if I go to the doctor, that has nothing to do with it. It just is that if you're able to receive services, it has to be a taxing effort for you to receive it in the hospital setting.
Other questions? Yes, please.
Aren't we very limited by the insurance provider though, in our choices? I mean, are the fees paid by the insurance provider?
Yes, and it really depends. If you're a Medicare, most of our clients are Medicare recipients.
Right.
There's the HMOs, there's the PPOs, and there's Medicare and private insurance. So, or there's people who do private pay as well. As long as there is a skilled need that the doctor feels that it's justifiable, it depends on what the conditions are and your diagnosis. A lot of families, I mean, we have a patient who needs wound treatment and a very severe stage, and we've had the patient for several months. Some cases, like I said, could only last 30 days, and it really depends. As long as there's a justifiable need for us to be in your home, we could be in your home from 3 months, 6 months, to maybe, we had a patient for about 8 months, but there was a lot of complications. So it just really depends on all the different needs that they have. But Medicare does cover it. Now, if we send all our records on a regular basis to Medicare, and we have a guideline to abide by, and if we come around that guideline that there is coverage, we do communicate to the family that we can no longer cover this for one reason or other. So that's when we look at options to either private nursing, or we look at different options to help them. But in most cases, we do help our clients figure out whatever the situation, but most of the coverage and orders that we get, as long as they're under our physician's order, we don't have a problem covering.
Well, because Medicare, even if you're Medicare, you have to have a provider. My mother has SCAN.
Okay, yes.
Are you familiar with that?
Yes, I'm familiar with
And
that.
I think I think that whatever selection we would make